Welcome, everyone, to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Well, there's new evidence that patients with stable CAD, that's coronary artery disease, and we'll explain a little bit more about that momentarily. Patients with stable CAD may be managed without stents or without a CABG, a coronary artery bypass grafting. And that is to say that optimal medical therapy alone may be the best option for patients with stable angina, that is mild chest pain as the result of CAD or coronary artery disease.
Here to talk to us about the latest findings is Mayo Clinic cardiologist, that's a heart specialist, Dr. Todd Miller. Welcome to the program. It's good to see you.
Thank you, Tracy.
So, Dr. Miller, they called this the ISCHEMIA trial. So explain that term and also what we mean by the term angina and coronary artery disease.
Well, let's start first with coronary artery disease. So beginning around age 20, based on autopsy studies from soldiers from Korea and the Vietnam Wars, it was known that plaque development starts at that age in people who live in the United States.
That's crud inside the artery.
Crud inside the artery, and it first starts out as a little fat deposition in the artery, and you would not be able to detect that with any of our current techniques. But over time, that fat buildup continues, and then it can start to calcify. And once it starts to calcify, we have methods now where you can image that and see the plaque buildup developing. So for men who are 50, men are usually developing this process at a more rapid rate than women. When men are 50, about half the men in the country will have detectable plaque buildup.
And is this whole process called atherosclerosis?
This is called atherosclerosis, hardening of the arteries, if you will. And once you start to develop enough plaque so that it blocks up the vessel, occludes the vessel by 50 to 70%, then you start to impair blood flow. So that's where the term ischemia comes from. So you don't impair blood flow at rest when you're 50 to 70% narrowed, but with exertion and exercise, you would start to impair blood flow with that type of narrowing.
The formal term for coronary artery disease would be if you have 50 to 70% blockage of the artery.
Then it's defined as clinically significant coronary artery disease.
Would that be in all three? There are three main arteries, coronary arteries, or could it be just one?
It could be just one.
So tell us about the study, the ISCHEMIA study.
Right. So as background for this study, this type of study has been performed for several years, going back 50 years. And the initial trials compared just medical therapy to bypass surgery. And around the 1970s, 7 large studies were performed, and they showed very little evidence that bypass either improves survival or reduces heart attack risk compared to medical therapy alone. So this concept that trying to fix the arteries by revascularizing them, doing bypass, has been around for a long time, and in the chronic setting, it's been difficult to show that you can improve longevity or reduce heart attack risk. There were certain subsets of patients with the worst plaque who had a little bit of benefit. And then following that, we've had half a dozen previous studies that use just stents alone compared to medical therapy. And also those studies reached a similar conclusion, where it was hard to show that longevity or heart attack risk were improved by doing stents. So the dilemma was people criticized those studies because in many of those studies, even though patients had blockages, they may not have had the impairment to blood flow, the ischemia. And it's been known from a lot of other studies that ischemia is a marker of patients who are at highest risk. So if you can demonstrate ischemia, which you can do with stress tests, you can show impaired blood flow and those patients are at higher risk. And so the ischemia trial was specifically designed to recruit patients who had significant ischemia on their stress test. That's the differing part of it from prior studies.
Ischemia, lack of blood flow.
Lack of blood flow.
To the heart muscle.
And not just a little bit. They had to have substantial ischemia. More than 10% of the heart muscle had to have impaired blood flow.
Okay.
So they tried to recruit the highest risk patients to see it in this high risk group, would stents improve outcome.
And how many patients did you have?
Worldwide, there were over 5,000, so this is by far the biggest study of coronary artery disease with an intervention ever performed. Previous studies, the largest they ever achieved was around a little over 2,000.
And how did you divide them out?
They were divided out by patients were randomized, so they had a stress test that showed a large area of ischemia. Then they were randomized, meaning their treatment was selected by a computer. Either they received medical therapy alone or they received a stent.
And what was the bottom line? What did you find out? And by the way, Mayo was part of this study, weren't you? You participated?
Right. Mayo was a part of the study. Out of the 5,000 patients, we contributed to 50 of the randomized patients worldwide. So we contributed a lot of patients compared to most other medical centers. So that was good for Mayo. Mm-hmm. But the major study findings were that outcomes, again, were the same between the two treatment groups. So the group of patients who received optimal medical therapy did as well in terms of survival and heart attack risk compared to patients who also received stents in addition to those treatments.
So that would suggest that we're overusing stents.
It sounds a little controversial there, Tom. And your hesitation is...
It's going to depend on who you talk to about that. But I think I would word it as saying that the benefit of stents has probably been overstated, okay? There's still reasons to use stents. People can be on good medical therapy and they can have ongoing symptoms that aren't well controlled with a medication. And in that setting, the stents can help improve the symptoms. And stents are clearly beneficial for improving outcome in the setting of acute heart attack. But probably even the chronic settings, some who are going to be very critical of the profession would say they're probably being overused in the setting of chronic coronary disease.
But if you have the stents, you're still going to be instructed as the patient going forward then to go back to some of the traditional medical therapy that other group used that wasn't stented.
That's exactly right.
And so what are those precautions, or going forward, what's that lifestyle?
Well, even if a patient who has chronic coronary artery disease gets a stent or not, the lifestyle measures, which are regular exercise and diet, are clearly the most beneficial for lowering risk when combined with correct medications. And the correct medications in patients with established coronary artery disease are aspirin. That recommendation no longer applies to the general public, but people who have established coronary artery disease should be on low-dose aspirin, and clearly they should be on a statin drug like Lipitor.
So that would be optimal medical therapy.
That's optimal medical therapy.
So just to make sure we understand, you had two groups of patients. One group, and all of them had ischemia, significant angina, chest pain and ischemia, meaning that part of their heart muscle was without a blood supply. And one group you gave optimal medical therapy, and you just described that. And the other group got either a stent or coronary artery bypass surgery, right?
Correct.
And after 3 years, there was no difference between the two groups with respect to what you call cardiovascular events, and that means death, myocardial infarction or heart attack, hospitalization for unstable angina, heart failure, cardiac arrest.
Absolutely right.
So bottom line is optimum medical therapy probably best for patients with stable angina and not a lot of chest pain.
Yes.
There was one thing I did read in the study, however, is that the patients in the second group who got either a stent or a coronary artery bypass surgery had less chest pain.
That's correct. So the quality of life indicators, both overall quality of life, how people rated how they were doing in general, as well as their angina frequency, were better in the group that got treated with stent or bypass surgery. But what you need to remember is that nobody was blinded to which treatment they were getting. They knew that they were getting stents or bypass surgery. And once people know that they're getting a certain treatment, there's a tremendous placebo effect from that treatment, and that could have influenced the quality of life results.
So if you think you're going to get better because of an intervention, you do.
That's saying it exactly correct.
All right. The results of the ischemia trial are in, and conservative management of patients with stable angina seems to be just as good as invasive surgery, meaning treatment with a coronary artery stent or coronary artery bypass surgery, correct?
Correct.
Our thanks to Mayo Clinic cardiologist Dr. Todd Miller.
Okay, thanks, Tracy. Thanks, Tom.